Welcome to MedOnepedia. My name is Benjamin, and today I'm going to be talking about gastric cancer or cancer of the stomach. So when we look at cancer of the stomach, we're going to begin with understanding the relevant anatomy and the physiology that is involved with how the stomach normally functions. So the stomach is made up of these parts. We have the part that connects from the esophagus, and that is the cardiac part, right here. Then we have the fundus of the stomach, we have the corpus of the stomach, and then we have the antrum of the stomach. So these different parts of the stomach are going to be affected by cancer in different ways, and different cancers will occur at different places, as we are going to see, because of the different cells that happen there. So when we look at, for example, when you look at the fundus, this is the fundus, the fundic unit of the cell. It has these cells, it has a cellular arrangement, these bits within here that where the cells are located. So some of the cells that we have here, we have the chief cells, we have the endocrine cells, which produce hormones like the intrachromaffin-like cells, which produce serotonin. And we have the EC cells, we have the D cells, and we have the P and the D1 cells. These are prostaglandin cells. Then when we look at the parietal or the synthetic cells, these are cells that produce our hydrochloric acid, and also they produce the intrinsic factor, which can also call the gastric intrinsic factor. And then the mucus or neck cells, which of course secrete the mucus that lines the stomach that protects us from this corrosive acid. So this is the fundic unit. And when you look at the antral unit, there's a small variation here. In the antral unit, we also have the endocrine cells, just like in the fundic unit. But again here, we're going to have the gastrin cells, which are not in the fundic unit. We are going to have the EC cells too, like the wire there, and then the D cells. And these D cells majorly produce somatostatin. Somatostatin has an inhibitory effect on these secretory cells in the G cells specifically that secrete gastrin. Gastrin is the one that influences the production of the hydrochloric acid, that is by acting directly on the parietal cells. So what happens is that some cancers are going to alter the way these things work. When you look at the risk factors and the pathophysiology, you shall understand that. But also one thing that is worth noting is the blood supply to the stomach, as well as the lymphatic drainage and everything else. So the stomach is actually well vascularized most of the times, and it has a very good anastomosis. And it gets its blood supply from very, very many different blood vessels. For example, in the lower curvature, we have the left and right gastric arteries, which come from the celiac trunk and from the hepatic artery. We have the gastroepiphyloid vessels that supply the greater curvature of the stomach. This outer one is the greater curvature, this inside one is the lesser curvature. And all these are going to have veins that follow them. On top of that, they're going to have nodes. So the stomach has very, very many lymph nodes, and this is what complicates most of the surgeries of the stomach, because they may require an lymph node dissection, and you may have to dissect very, very many lymph nodes. So when we look at gastric cancer, we have some risk factors for developing the cancer, and we have the modifiable and the non-modifiable risk factors. And the modifiable include the H. pylori infection, which is more common in the low economic status countries. We have diet, that is a diet high in salt, smoked foods, preserved foods, and low fruit or vegetable diet has also been implicated. Then we have smoking and alcohol, we have obesity, we have chronic gastritis or pernicious anemia. And this is type A gastritis, the autoimmune gastritis that results into pernicious anemia. Then we have previous gastric surgeries. For example, if there was maybe a period one, we may have what we call a stump carcinoma, which is cancer that develops at the site of anastomosis. Then you can have occupation exposure to things like coal, metal, and nova. Then the non-modifiable factors, we have things like age. Of course, as you age, most times there is an accumulation of carcinogens or exposure to carcinogens which cause cancer. Male sex, being male. Ethnicity, people come from East Asia, because the highest rates of gastric cancer have actually been reported in countries like Japan and Korea. And then Eastern Europe, South America. Then we have a family history where we have some genetic syndromes like the CDH1 CDH1 deficiency, people with Lynch syndrome, Leaf-Romani syndrome, and then people with blood type A have also been implicated. So when you look at the histologic classification, and we have very many classifications of stomach cancer, but the histologic classification is one of the mostly used and mostly the mostly widely used or referred to because of its simplicity. But when it comes to management and other things, we have other classifications like the Borman classification according to the morphology, which I will not cover in this video, but it's important to know that they exist. So we have the Laurin classification, which has the intestinal type and the diffuse type of gastric cancer. And in the intestinal type is one that is well differentiated and it affects the glands. So what will basically happen is that we have a change in the epithelium or the lining of the stomach from the normal lining of the stomach, which has glands. The glands are removed, and then we have what we call an intestinal metaplasia. So the lining in the inside of the stomach starts to resemble that one of the intestines. And then because of this, we have a dysplasia happening, which is proliferation of cells now that are malignant or have changed. And it is more common in older males, but the diffuse type is seen more in the younger ones. It is more aggressive and it affects almost the whole stomach. So the intestinal type is either going to affect the fundus or it's going to affect the pyloric area, where we have most of the glands in the stomach. But the diffuse type is almost going to affect the whole stomach. It's more aggressive and it is most times not associated with H. pylori. And then it is characterized by what we call the signet-rig cells. When they do histology, they see these cells, and it is a poorly cohesive kind of cancer whereby everything is far apart from each other. Unlike the intestinal type, where you may just find the tumor is in one place but not spreading out. So adenocarcinoma is going to be the most common type of cancer of the stomach, and these are the two types of adenocarcinomas. We have an intestinal type and a diffuse type. Then we shall see other cancers that arise in the stomach, like the GIST, the lymphoma, and those are also other kinds of cancers that are less commonly seen. Then we have the mixed type of cancer, where we have features of both the intestinal and the diffuse carcinoma. So when you look at the pathogenesis, what really happens for us to develop this cancer? We have a chorea cascade or for the intestinal type of cancer, whereby we have a chronic gastritis. Now, when we have a chronic gastritis, it's going to cause destruction of the glandular tissue. And when you destroy the glands or we have atrophy of the glands, we're going to start having a kind of a kind of lining in the stomach that resembles that of the intestine, which we call intestinal metaplasia. And when we have intestinal metaplasia or change in the type of epithelium, most times we can easily go to dysplasia, where now the epithelium now starts to not even look like anything. And when we have dysplasia or poor differentiation, then we can head to a carcinoma. And there are some other mechanisms that have been involved. For example, in the intestinal type, that's associated with P53 defect, APC gene, the beta-catenin mutations, which lead to this glandular tumor. Then in the diffuse type, we have the E-cadherin loss. And E-cadherin is important in holding things together. Most of the time when you lose E-cadherin, then that's when actually these cells start to disseminate everywhere. So when we have CDH1 mutations, which lead to cadherin loss, we are going to have scattered cells, and then you have signet-rig type of appearance. And then we have chronic inflammation, and this is going to come from reactive oxygen species, and reactive oxygen species are going to cause DNA damage. And when you have DNA damage, ultimately we shall have mutations. Then we have the H. pylori law, where H. pylori is found to have the CAG-A and the VAC-A genes. So the CAG-A is going to cause proliferation, uncontrolled proliferation of these cells in the lining of the stomach, while the VAC-A is going to cause a toxin, the VAC-A toxin, and this one is going to cause a chronic gastritis. And this, when we have this, we're going to have destruction of cells. So when you have destruction of cells, like for example, if we destroy the D cells in H. pylori causes destruction of D cells, we are going to have an increased production of gastrin. And when gastrin is too much, at first we're going to have proliferation of parietal cells, but after a long time, that chronic inflammation that is taking place in the stomach is going to actually now destroy them, and we have atrophy. So when you have atrophy, the acid is going to go down. When acid goes down, we have what we call the hypochlorhydria, and then bacteria will start overgrowing the stomach, which is not common because the pH there is normally always high. So when you have bacteria overgrowth, there is production of nitrosamines and other things, and in the end, the lining is going to start looking like the one that is in the intestines, because it's the intestines where we have low acid and where we have actually bacterial overgrowth. So we have a metaplasia, and the metaplasia is going to lead to a dysplasia, and the dysplasia will then lead to carcinoma. Then we have the gastric environment changes, and it's the same principle. We have atrophic gastritis, decreased acid and intrinsic factor, where someone gets the anemia now. And sometimes you have the proton pump inhibitors, which is a theory that has been come up with, but nobody has yet confirmed it, that because of the hypochlorhydria and increased gastrin, we may have an altered microbiome whereby the stomach is less acidic. So microbiome is going to grow up in the stomach, and then we have changes. Then when you look at spread and invasion, the basics of it is that we have the local invasion where we have wall infiltration. So when we are looking at even the staging of the cancer, we are going to stage it coming from inside going outside. So when you look at the TNM staging or the TM grading of the cancer, which look like a T1, which is about at the mucosa. As you go inside, you enter the submucosa. As you go inside, you go to the mascularis, then you go to the serosa, then the serosa, and this will always give you different tumor gradings. Then when you look at the lymphatics, along the arteries that supply the stomach is where actually the nodes are. So if you understand the arteries that are supplying the stomach, then you know the lymph nodes of the stomach. And ultimately, most of these nodes are going to pour into the supraclavicular lymph nodes, and that's where we have the vacuous node. And this is a very, very important sign when it comes to showing malignancy. Whenever we have a vacuous node involved, we suspect that we have a gastric carcinoma. Then hematogenous spread can be going to the liver, because first of all, the blood supply, of course, goes to the drainage goes to the liver and to the lungs, then the bones ultimately. Then we have the transcelomic trade, where through the peritoneum we have spread of these cells downwards. And when they go to the ovaries, we get what we call the Kuchenbach tumors. So the classification or the staging is done by the TNM grading, and after that we have the AJCC 8th edition staging, which you can look up and understand. So when it comes to the clinical manifestations, the key features are going to be grouped into the early, the advanced, and then the metastatic warnings. So earlier on, we shall have, often it's asymptomatic. Someone may have mild dyspepsia, then they have nausea, early satiety, and weight loss is a very important thing. So when we look at someone with gastric ulcer, the most commonly going to complain of early satiety and weight loss. Then as the thing advances, we may have heavy gastric pain. We may have vomiting if we have pyloric obstruction, because imagine we have a tumor down at the pylorus. It is going to obstruct the outflow, and then it obstructs the outflow. Someone is going to have postprandial vomiting. So someone eats and then they vomit within a short time after eating. Then we have anorexia, we have anemia, we have melena, which is of course bleeding, that black stool because of partially digested blood from the upper GIT. Then you have palpable epigastric mass. When we look at the metastatic warnings, and I told you the vacuous node is very important to show that things have gone out of hand. Then we have the Sister Mary Joseph nodule, which is at the umbilicus. So when you look at the umbilicus and we have this Sister Mary Joseph nodule, we can tell that this patient has advanced gastric carcinoma. Then we have the Kuchenbach tumors, which are ovarian metastases. Right? Then we have what we call the Blumei shelf, which is a rectal shelf that you feel on the rectal exam. Then we have the Tresor syndrome, and Tresor syndrome is a migratory thrombophlebitis, where we have someone developing clots in blood vessel, but the clots appear, they disappear, and reappear in different places. That is the Tresor syndrome, and it's also an important thing to note about metastatic features of gastric cancers. Then we look at the management. Most times the only cure for gastric cancer is going to be surgery, which is a RS node resection, which means complete tumor removal. We want to remove the tumor and leave no margin. And depending on the extent of the tumor or the location, you can do a total or a total gastrectomy. So tumors that are distal, that are far away, that are down, we can do a subtotal gastrectomy. But now, whenever the tumor is closer to is proximal, closer upward, we normally do a complete gastrectomy because it would be actually hard to anastomose when we have cut away most of the chunk of the stomach. And this comes with a lot of its own complications when it comes to the diet and everything. Then we want to do lymphadenectomy. And when you do lymphadenectomy, you can do the D1, which is limited to the regional lymph nodes of the stomach. These are the lymph nodes that are around the short gastric arteries, the gastric artery, gastric epiploic arteries. We just go and remove the lymph nodes around there. And then we have the D2, which is extended, where you extend now to the celiac trunk, which gives off the branches. And we go to the hepatic trunk, which also hepatic artery, which gives off branches, and remove the lymph nodes there. That is the extended. Then we have the neoadjuvant or adjuvant chemotherapy, where neoadjuvant, we want to shrink the tumor, we want to give the chemotherapy to shrink the tumor and then resect it. Whereas we have the adjunct chemotherapy, which we give after surgery to increase on the destruction of these micrometastases, the cells we did not see during surgery. We try to kill them now with chemotherapy. Then we have the targeted therapy, where you can use the HER2. When we have HER2 positiveness, we can use trastuzumab. Then PTL1, where we use nivolumab. Then it can be palliative when the tumor has gone out of hand. The tumor is very big and unresectable. We can do palliative care, where we can do endoscopic stenting for the obstruction. To relieve obstruction, we can do palliative care therapy, we can do nutritional support and symptom control. Then we can give the supportive or the pre-op optimization, where we have to make sure we correct anemia. We want to optimize nutrition and manage infections before or after we had surgery. So the complications, we can have the local complications, the post-surgical, and the metastatic or the distant. The local complications of the tumor include bleeding, perforation, gastric outlet obstruction. The post-surgical, we can have leak at the anastomosis, and we can have damping syndrome. And damping syndrome is when we have a quick transit of intestinal contents that are acidic right into the intestines. And this is going to cause diarrhea because the contents are coming and they're hyperosmolar. When they are dropped into the ileum, they're going to lead to a secretory diarrhea. And this patient is going to have a lot of diarrhea and other associated the associated syndromes around that. Then we can have nutritional deficiencies like vitamin B12, because we know intrinsic factor is produced by the parietal cells, and now we have cut away the stomach, fat-soluble vitamins, and so on. Then we have the metastatic or the distant, where we can develop ascites when there is peritoneal spread. Liver metastasis will cause jaundice, hepatomegaly. Then we can have both metastases that can lead to bone pain and fractures. Then when you look at the prognosis, gastric carcinoma has a really bad prognosis, and most times it take different, and the 5-year survival most of the time is not even good. And after 5 years, really the survival rates are very, very, very low or close to zero. So when it's early and just in the mucosa or submucosa, the 5-year survival can reach up to 90%. When it's advanced and beyond the serosa, normally the survival rate is less than 20%. And the bad thing about gastric carcinoma is that most of the time it's called in the late stages. Then we have the prognostic type poor prognostic factors, like for example, if you have a diffuse type, this is very bad. If you have a node positive disease, this is also bad. If you have distant metastasis, it's so bad. If a tumor is greater than 5 centimeters or it is in the proximal location, this is also not good. Then better prognosis if you have the intestinal type, if there is early stage detection, and if there is complete iron node resection where all the margins are negative for the tumor. Then when you go to other types of tumors, we have what we call the GIST, the gastric interstitial stromal tumors. And these ones come from the interstitial cells of Kajal, that is mesenchymal. And they're distinct from the smooth muscle tumors. So the location, they are found in 2/3 in the stomach, and the others are usually solitary. So these tumors actually have a potential to occur elsewhere outside the stomach, and they're associated with markers like the c-KIT, the PDGA flora, actin desmin, and that is what is actually going to differentiate them from the leiomyomas or the fibroids. So clinically, they are small, so they are most of the time incidental, and when they are large, When they're small, they're just incidental. Maybe you're doing endoscopy and you find them. When they are large, they're going to cause bleeding, pain, fullness, acidity, and a palpable mass. And metastasis is mostly hematogenic, so they may just spread to the liver and the lung. The diagnosis is by endoscopy and biopsy, and we can do endoscopic ultrasound to tell the depth. And after that, we can do the CT for staging these tumors to rule out to see which nodes are affected. Then the management is going to be surgery, where we can do resection with clear margins and block if invasive, and then adjuvant we can do, or metastatic we can do imatinib, which is targeted therapy. So if there is resistance, we can use the newer TKIs. Then the prognosis, the 5-year survival is 80% if it is low grade, which means if it's well differentiated, but if it's poorly differentiated and it's high grade, there's a 30 to 50% risk. So when the size and the size and the mitotic count and the location of this tumor is what is going to determine the risk of these cancers or the complications associated with the cancer. Then we have the gastric lymphoma, and the gastric lymphoma is important for most especially in our low economic settings where we have chronic H. pylori infection. So what happens is that the stomach normally doesn't have lymphoid tissue, but because of chronic infection with H. pylori, the stomach is going to start developing these lymphoid tissues. Think of it like there's a crime happening in a place and the police decides to open up new police stations there that were not there before. So these lymphoid tissues are going to come in like that. So when they come in like that, we're going to have now what we call the MALT, the mucosal associated lymphoid tissue. And it can be high grade or low grade. So when it was high grade and you do H. pylori eradication, most of the time it is going to regress back to normal and the lymphoid tissue are going to regress. But if it is hybrid, then we may need to use things like radiation and chemotherapy. So that is for it. And most clinically, we may have dyspepsia, we may have bleeding, we may have obstructions, we may have B symptoms, and then lymphadenopathy. Remember, it is a lymphoma, so B symptoms should always are almost there in 50% of the cases. And then we can have lymphadenopathy, organomegaly, and then systemic disease. And lastly, we're going to look at the gastric carcinoid tumor, and this is the tumor of the enterochromaffin-like cells, and these cells actually produce serotonin. So what causes this is hypergastrinemia. So things that cause gastritis and they destroy the parietal cells like H. pylori, like photoTRAP inhibitors, pernicious anemia. We're going to have increased gastrin secretion, and gastrin leads to hyperproliferation of the epitheliums of the stomach. So what happens is that we're going to have types of this gastric carcinoid, and they can be type 1, type 2, and type 3. Type 1 is 75% of the cases. It's multiple, small in women and has low malignancy, and it's most associated with the hypergastrinemia. Then type 2 is associated with the MEN1 syndrome or the Zerlinger-Eliasson syndrome, and for which it is multiple, small, and the malignancy is approximately 10%, and it's associated with the gastrinoma, which is a tumor that is producing gastrin, which makes sense because we said when we have a high gastrin, there's increased proliferation of glandular tissue in the stomach. Then type 3 is sporadic, solitary, greater than 2 centimeters, occurs in men, high malignancy, metastasis, and it's going to be associated with the carcinoid syndrome, which is things like headache, sweating. These are going to be the features of increased serotonin. And clinically, it's often asymptomatic. We may have bleeding and mass effect because of the size of the tumor. And then carcinoid syndrome is going to be common. The diagnosis is going to be by endoscopy, and we can do a biopsy. If it is submucosal, sometimes we may need to do endoscopic ultrasound. So you realize that most times when we have cancer of the stomach, we do endoscopic ultrasound to see the depth of the cancer within the wall. Then we can do a CT with octreotide for staging. The management, we have type 1 and type 2 where we can do AMR plus follow-up. And type 3, which is AMR is endoscopic resection, and then we follow up. Then large type 2, where we can do a D1 or D2 gastrectomy depending on the extent because of the high malignance potential. Then type 3 gastrinoma. Type 2, if there's a gastrinoma, we can resect this gastrinoma. Then somatostatin analogs can be used to relieve symptoms because somatostatin is going to stop the action of gastrin, or it's going to reduce the production of gastrin. So we have symptoms or antiproliferative control. And we can do debulking in some cases because these tumors are going to actually cause the mass effect. So we can debulk, we can remove them to allow reducing excess. Then the prognosis, type 1 is 100% if it's not negative. It's greater than type 1, 100% is non-negative, greater than 90%. And then type 2, if it's not positive, the chances of survival are type 3, the not positive, the chances of survival are less than 50%. So we have come to the end of this video and we have discussed a lot about the different gastric cancers. I hope you enjoyed this video. My name is Benjamin. Have a nice day.